Let's talk about the ERA test, otherwise known as the Endometrial Receptivity Array. So this is a test that promises to pinpoint your personal window of implantation in the lining of your uterus. The window of implantation is a 5 to 6 day stretch that happens during the luteal phase of your cycle when your uterine lining is exposed to progesterone, and it becomes most receptive to an implanting embryo. The idea is that if we can find this personalized window for each individual, then we could, in theory, time your embryo transfer very precisely to improve your individual chance of success. This test was originally developed with the issue of recurrent implantation failure in mind. It was based on this theory that maybe for some people the embryo and the uterus are just not syncing up correctly. Sounds plausible, right? Except this idea that people are just walking around with uterine linings that are out of sync with their hormonal cycles has never actually been proven to be a real legitimate problem. So how does the ERA test work? Well, you go through a mock cycle where you're taking estrogen and progesterone just like you would for a medicated prep for a frozen embryo transfer. But instead of actually transferring an embryo, your doctor will instead do a biopsy of your uterine lining, and that tissue is sent off and analyzed to look at the expression of 238 different genes. Based on that gene signature, the report will tell you if your lining is receptive or whether you could be someone that would benefit from taking a longer or shorter duration of progesterone leading up to your embryo transfer in an effort to shift the window of implantation. I want to break down several reasons why I feel, and many others feel, that the science just isn't there to back this up. Well, for one, when it comes to embryo transfer success, the lining is rarely the problem. Most IVF failures are due to embryo quality issues, especially in cases where there aren't obvious problems that are structural like fibroids, scar tissue, or adenomyosis. In fact, studies have shown that after 3 consecutive embryo transfers, especially of euploid embryos, the vast majority of patients will be pregnant. And that tells us that unexplained recurrent implantation failure is actually not that common. Implantation is incredibly complex. It involves gene expression, hormonal signals, anatomic changes, and even communication between the embryo itself and the lining. This is called embryo-endometrial crosstalk. And we're nowhere near really fully understanding this process, let alone being able to measure it in an objective way, in a reliable way, on the basis of a limited panel of genes that are being tested in a preceding cycle where there isn't even an embryo present in the uterine cavity to influence the environment. Secondly, there has yet to be studies that consistently show an improvement in live birth rate when using the ERA test. The only randomized controlled trial to date did not show any benefit, and there are several other large studies, including one specifically looking at patients that were using euploid or genetically tested embryos that found no difference in pregnancy or live birth rates. And one study even showed that doing an ERA might be associated with a lower pregnancy rate in donor cycles. In other words, there's a chance that using this test to guide how much progesterone to give before transfer might actually detract from the outcome. One of the biggest problems that I have with the ERA is poor reproducibility. We know that the window of implantation isn't necessarily fixed, and like our periods can change from cycle to cycle, it can shift. And anyone that's had a period knows that every month can be slightly different. So when you do the ERA, it's based on a mock cycle before the actual transfer cycle. It's not the real one with your embryo. And that is also a major flaw because, as I mentioned earlier, the embryo can talk to the lining, and the embryo being in the uterine cavity can actually influence the lining and the genes that are expressed. So the environment that is being tested in the mock cycle is actually different than the one that is happening when it matters during the embryo transfer. Even within the same patient, we have studies that show that gene expression results can vary depending on their hormone levels, the timing of the biopsy, the lab's methodology, and more. So there's a lot of biological noise. And something a lot of people aren't aware of is that the initial technology that this test was based on and the big first studies that came out on it showing a benefit, they were using outdated technology called microarray. Nowadays, we rely on something called next generation sequencing to more accurately capture gene expression patterns. All of the studies done were in the setting of medicated mock cycles. So we don't know if any of the findings from prior studies actually apply to people doing natural or unstimulated cycles. And it hasn't been studied in diverse patient populations. Now I can already predict that there will be people in the comments that say, well, my transfer failed and then I did the ERA and we adjusted my progesterone by 12 hours and then it finally worked. So why should I listen to you? If I didn't do the ERA, I wouldn't have been successful. But that is not true. Getting pregnant after doing the ERA or taking a supplement or trying any experimental treatment for that matter doesn't mean that the intervention actually helps you get pregnant. It could have been a different embryo, it could have been something different about your lining, or just plain chance, especially when we know that shifting progesterone by just half a day likely doesn't make a clinical difference. Studies have proven that there can be this type of level of variation in progesterone administration with no difference in pregnancy rates. There's also a major lack of clarity in terms of who this test can actually benefit. There's no guideline recommending the ERA. There's no data to guide, its use and who it would best benefit. We know that there are many clinics that started offering it routinely before someone's first transfer. And the cost is very high. It can cost thousands of dollars for something that does not clearly help. And personally, as someone who has done RNA sequencing research to look at gene expression, my research involved embryos, I know how much noise and variability there can be in the data and how it can get interpreted in many different ways. So I would never trust a limited panel of 200 something genes to dictate how much progesterone I'm going to give to my patient. I'd rather rely on the protocols that are actually standardized and have produced our current success rates from thousands of data points and thousands of cycles from the past decade.